So I was always intimidated by cranial nerves. Um, they're starting to get a little better for me, and I think just thinking about them as kind of spinal nerves that are just coming out of your brainstem and a few out of your brain. Um, that kind of helps a little bit, just thinking about them like spinal nerves of the brainstem. 12 pairs of these we've got, right? Um, so they do carry motor, sensory, and autonomic information, kind of like your spinal nerves do, but your spinal nerves carry all of those. Every spinal nerve has motor, sensory, and autonomic. Cranial nerves are a little different, is that some only carry motor, some only carry sensory, some carry a mix. And then also you've got those subserving, those special sensory functions, vision, hearing, taste, those kind of things. So there's a few unique things about them. And equilibrium, balance. Here's their three major functions. So kind of just good to start with the broad picture here. They are motor to your muscles of your face, eyes, tongue, jaw, and two of your neck muscles. Okay. They provide somatosensation, so musculoskeletal and skin sensation for the face, TMJ. They also have special sensory information related to vision, hearing, inner ear, vestibular, taste, smell, and then also visceral sensations, the sensations you feel from your viscera that don't always make it to conscious awareness, but that's how your parasympathetic and autonomic system react and adapt based on that visceral information they're getting. And then they have the parasympathetic component, because these are in the cranial nerves, parasympathetic. Remember, cranial and sacral nerves are their parasympathetic. So this is parasympathetic regulation of heart rate, blood pressure, breathing, digestion, and a little bit of the eye. Okay, so ciliary muscle function, pupillary constriction, a little bit of elevate. Well, that's sympathetic as elevation of the eyelid, but. So here they are. This is looking at the inferior surface of your cerebrum and kind of inferior ventral surface of your cerebrum and brainstem. When I look at them and kind of count my way down through them, I kind of start from a picture like this, just kind of start at the top and work our way down, and start kind of medial here. And so we have olfactory right here is the first nerve you run into as we look down this from the top to the bottom. And then we run into the optic nerve, number 2. Then we keep staying in the middle here, and we run into the trochlear nerve here. Actually, that's not trochlear nerve. That's oculomotor. Sorry. Yeah, cranial nerve number 3, right here. It stays in the middle. It's right in that interpeduncular fossa between the brainstem has the cerebral peduncles. They're coming out of the interpeduncular fossa, that gap between the two cerebral peduncles right here. This is your midbrain. Once you get to that spot there, and you get to this division here between the pons and the medulla, there's a little bit of a sulcus fissure here between the pons and the medulla, then you start counting kind of out, start moving laterally. So we kind of come down this way, down through the middle, and then start counting out laterally. Then we run into the trochlear nerve, okay? Then the next nerve, that's 4. Then we get to 5, the trigeminal nerve. And then once you get to the edge of here, just jump back to the middle here. When we get to, this is the pontomedullary junction between the pons and the medulla. And then you're going to count again from medial to lateral and work your way down the side of the medulla here. And so right here in the middle would be abducens. And then we have facial nerve is next, and then vestibulocochlear nerve. And then vestibulocochlear is the auditory vestibular nerve they're showing there. And then glossopharyngeal, and vagus is the next one, and then spinal accessory, which you see branches of the spinal accessory are coming up from the actual cervical vertebrae to contribute to the spinal accessory nerve. That is actually that nucleus for that is down in the first few cervical segments. Okay, and so then once you get to 11, you jump one little sulcus forward here. This kind of called this the ventro-intermediate sulcus or fissure on the front of the medulla, and that's where your hypoglossal nerve comes out of right there for your tongue movement. Okay, so that's how you kind of work your way through the, cranial nerves as you count them through. You should know this, the number, the name, what its primary functions are, and then this is the connection to the brain. This is basically where the nucleus for those cranial nerves are located. And we'll show you that as we go through each of those, kind of getting a sense where the information from those nerves either comes in or is going out from. Okay. There is plenty of different mnemonics out there. This is just one I pulled off. I don't know if anybody came across some, but there's a variety of mnemonics out there. And there's usually a mnemonic for just memorizing the first letter of each of the cranial nerves and kind of just giving you a cue of what to think of there. And then there's mnemonics that help you understand, is it a pure sensory nerve? Is it a motor, pure motor, or is it a mix? Okay, and so that's what that can be helpful for some. I've finally gotten to the point that I don't have to rely on those. It only takes 20 years. Cranial nerve number 1. We're just going to go right through these. Olfactory nerve, you don't need to know much about it because it just doesn't mean that much to us as physical therapists clinically. It's a pure sensory. It's got chemoreceptors. Okay, that's sensing the molecules in the air. That's what we provide with smell. Conducts information from the nasal receptors directly into the medial temporal lobe. So this is one of the few, if not really the only, cranial nerve that goes directly into the brain. Doesn't go to the brainstem. It goes directly into the brain and directly into that medial temporal lobe, which is part of your limbic system. So it goes to limbic system structure. So in that sense, it's a very kind of primitive sensory experience that smell is. It's very attached to just our primitive kind of, hunger and sensing things in the environment, and also smell can trigger emotional responses too. So we associate a lot of memories because the medial temporal lobes are also the hippocampus, so smells can bring back memories. And I think as far as evolution and those kind of things, smelling a certain thing and understanding whether that's a rotten vegetable or that's something you should or shouldn't be eating, and those kind of things are really why it goes to that primitive kind of response, so you don't ever eat that bad thing again, or some of those kind of things, and also just for responding to your environment. We can appreciate about 10,000 different individual scents, and we actually recognize a lot of those smells as a taste. Okay, so most of our taste comes from our smell, and you've probably all experienced this when you've got a really blocked up nose and a cold, how nothing actually tastes that great. I mean, I've had colds where like I'm eating something that really is like really good, like a pizza or something, or some like chocolate, a brownie or something, and I'm like, this is not even worth the calories right now because I'm not actually enjoying, I'm not getting the full experience of this, so why bother? I'll wait till like my nose clears up so I can really chow down on this and enjoy it. But and this is another reason why a lot of your older adults, and we're in geriatrics right now, you start losing some of these receptors and they get less sensitive over time, or somebody's a chronic smoker that can damage those, and they end up not having a lot of taste because their smell isn't that great, and so then it's not that satisfying to eat. So you're trying to force this old person to eat, and they're just like, I really don't care about eating. It's something I got to do. I know to sustain my body, but I don't get much pleasure anymore out of this. So when you test the cranial nerve number 1, you present common smells to each nostril individually. So you have the patient, or you usually have the patient block their nose, and you present the smell to each nostril individually because these are going to different lobes, different temporal lobes. Here's the things. The problem is a lot of times mucus, deviated septums, those kind of things can be the reason they have the problem with smelling, not because they've got a nervous system problem. Difficulty recognizing all scents is called anosmia. Okay, if it's on both sides, it's bilateral anosmia or unilateral anosmia. Don't use ammonia to test smell, because ammonia actually irritates free nerve endings, and you can sense ammonia because it causes noxious stimulus up in your nasal cavity. So that's not a good way to test somebody's smell. Present some common smell, usually coffee, lemon, orange type smell, something like that, these little essential oils or something like that as common smells to help them see if they can smell those. Can indicate, medial temporal lobe problems or frontal lobe problems if they have damage. If somebody that says a traumatic head injury and they know that they got some frontal lobe impairment, the speech therapist, the dietitian may test their sense of smells to see if they've got any problems with that. Moving on to cranial nerve number 2, the optic nerve. Pure sensory, okay? The optic nerve, information comes in the optic nerve. It first relays that information to a couple different areas. One is called the lateral geniculate nucleus. And then there's some branches of the optic nerve that also go to an area of your midbrain, okay, called the pretectal area, just in front of the tectum, where those inferior and superior colliculi. It's getting the pretectal areas right in front of the superior colliculus. The lateral geniculate nucleus then relays that visual information to the primary visual cortex via the optic radiations. The information that goes to the midbrain, to that pretectal area, that's for mediating pupillary reflexes, basic awareness of light. You can sense light in your midbrain. So somebody can have cortical blindness where their cortex back here in the occipital lobe region is damaged and still sense light and dark because of the midbrain can appreciate some light and dark. And then also with that reflex orienting of the eyes and head to visual stimuli, that's mediated by the midbrain centers. So this is showing you this very basic kind of feature here. Here's your optic nerve right here. This is your optic chiasm where parts of your vision cross, but don't worry about that right now. You're going to talk about that with Megan from the Neuro Rehab Balance Center comes to talk about vision and vestibular systems, showing it go in a little more detail on that. And I'll do a little review on that as well with you guys at a future lecture. But so we'll just kind of follow this out here. It goes from the optic nerve. This is the optic chiasm. Once we get through the chiasm, now this is called the optic tract. And there's a thing called the lateral geniculate nucleus back here. And actually what the lateral geniculate nucleus, your thalamus is sitting right in here on each side. The lateral geniculate nucleus is a nucleus bump off that posterolateral, inferior posterolateral surface of your thalamus. So it's kind of really attached to the thalamus and kind of bump off the back of your thalamus. Your thalamus is a relay center. The lateral geniculate nucleus is a relay center. You got to go to the lateral geniculate nucleus before you talk to the brain. So it's kind of like a little subdivision of the thalamus, but it's its own distinct structure here. And then it goes through the optic radiations. This is the optic radiation. It's making this little jog here. This is your lateral ventricles are in here, and it has to jog around your lateral ventricle. It does this little jog around that. That's what that is. It's called Meyer's loop there. It kind of comes off and goes around the lateral ventricle. But then you'll notice that before it even gets to the lateral ventricle, lateral geniculate nucleus here, some optic tract fibers branch off to go to this pretectal area. Here's your tectum, this is your superior colliculus. These bumps off the back of your midbrain. So it's going to this pretectal area for mediating midbrain responses to basic changes in pupillary constriction, accommodation reflex, which is the curvature of the lens. This is how the afferent information gets in. This is how you got to get the light information into the midbrain so that the midbrain can efferently respond and constrict the pupil, change the curvature of the lens, those kind of things. Okay. So to test the cranial nerve number 2 is you test for oftentimes pupillary light reactions. So you hold a flashlight up to the corner of their eye. You look for the constriction of the pupil. You also look for the consensual, which is the opposite side. You've got a lot of bilateral wiring when it comes to the eye, and so you'll get constriction. Even if you shine light in one eye, you'll get constriction in the other eye. Okay, but all you're testing here is the afferent component. You have to get light into the eye. This doesn't cause the pupil to constrict. There's an efferent component, which we'll talk about, which is oculomotor nerve. Cranial nerve number 3 is the efferent limb, or the efferent part of that. This is also the afferent part for the accommodation reflex. Accommodation reflex is focusing on objects as they get really close and near to you. Your eyes come in a little bit, the pupils constrict a little bit, the ciliary muscle contracts a little bit. All those are part of the accommodation reflex, but this is getting the image to your retina so your midbrain knows what to do and send the signals out. So this is just getting the image in there. We might screen the optic nerve looking at visual fields. Okay, can the person see in the peripheral vision and so forth? And then acuity, so looking at an eye chart or holding up a little eye chart card. I usually just have a card that they hold up because it's not always that you see them, you have them on the wall easily accessible as a PT, but I can just hold up a little card about 14 inches in front of their face and go through that screening. Okay, so that is how we test the optic nerve these different ways. Now we get to talk about 3 nerves all as a group, so we'll bang out 3 of them all here real quick here. This is the oculomotor, trochlear, and abducens nerves. We're going to put those all in a group because they have one thing in common, is they all contribute to eye movement. Okay, the oculomotor nerve also does some other things as well, some parasympathetic control. It's the efferent limb of what we just talked about, for the pupillary constriction and all that kind of stuff. But we'll go through each of those. So primary control of eye movements. We also have reflexive constriction of the pupil through cranial nerve number 3. It's the efferent part of the pupillary light reflex. So once the light gets in, this is how you drive the response to that light. And there's a little nucleus in that pretectal area called Edinger-Westphal nucleus. And that's the nucleus, that's where the preganglionic parasympathetic fibers start in the Edinger-Westphal nucleus for this. Okay, and then they also help contribute a little bit to elevation of the eyelid as well through cranial nerve number 3. Okay, also a few parasympathetic fibers that go to a few smooth muscle fibers that help elevate your eyelid a little bit. Okay, the nuclei associated with these different cranial nerves. So for cranial nerve number 3, you have the oculomotor nucleus, which is the one that goes to the muscles, the striated muscles of your eye to make your eyes move. Okay, and the Edinger-Westphal nucleus, which is the parasympathetic nucleus component to that. Okay, then we have a cranial nerve number 4, trochlear nucleus. The trochlear nucleus goes to the superior oblique muscle. But anyway, and then we have cranial nerve number 6, which is the abducens, in the abducens nucleus. The abducens nerve, abducens nucleus. Makes sense? Trochlear nerve, trochlear nucleus. Okay, so we have a nuclei associated with these. So let's talk about control of eye movement. We have 6 extraocular muscles. These are muscles outside of the eye. We have the ciliary muscles inside the eye, but these are extraocular muscles. We have what are called the recti muscles. We have 4 recti muscles. We have a superior, medial, lateral, and inferior recti muscles. Rectus is straight. They're relatively straight, okay, how they attach to the eye. We also have what's called the superior and inferior oblique muscles, which we're going to show you a video that makes a lot more sense of this. I finally found a really good video that shows you how these each contribute to eye movement. All the muscles are innervated by cranial nerve number 3. Okay, for the extraocular muscles, except for SO4, LR6. Superior oblique is cranial nerve number 4. Lateral rectus is 6, and that's kind of how I've learned it or remember it. SO4, LR6 is what I do. So then everything else you just know is cranial nerve number 3 that innervates it. This is just showing you looking down. This would be a left eye, looking superiorly down at that left eye, and I'm just going to show you the video here to show you how these muscles are attached and how they work here. Let's hope we have sound.
This time Understanding the actions of the extraocular muscles can be frustratingly confusing, so I hope this video helps. You may also want to watch a video on eye movement terminology before this one. The eye sits within the bony orbit. The orbit has a roof, a floor, a medial wall and a lateral wall. It is therefore somewhat pyramid-like in shape. The two orbits have medial walls that run parallel to one another. The lateral walls are at about 45 degrees to the medial wall, or 90 degrees to one another. The eye sits within the middle of this space, with the four recti muscles converging on the orbital apex, where they insert into the annulus of Zinn, a fibrous ring of tissue that encircles the optic nerve. These recti are superior rectus, medial rectus, and inferior rectus, all supplied by the oculomotor or third cranial nerve, and lateral rectus, supplied by the abducens or sixth cranial nerve. The inferior oblique is also supplied by the oculomotor nerve, while the superior oblique is supplied by the trochlear or fourth cranial nerve. Contraction of the lateral rectus abducts the eye, while contraction of the medial rectus adducts the eye. The two opposing muscles are described as being antagonists. Sherrington's law of reciprocal innervation states that when a muscle is stimulated, its antagonist is inhibited. This means that abduction is a combination of contraction of the lateral rectus and relaxation of the medial rectus. As well as having an antagonist muscle, there is also a yoke muscle which achieves the same movement in the other eye. So for right gaze or dextroversion, the lateral rectus abducts the right eye, while the medial rectus adducts the left eye. Herring's law states that yoke muscles receive equal and simultaneous innervation, the magnitude of which is determined by the fixing eye. When the eye is abducted 23 degrees, the superior and inferior recti are aligned with the axis of the eye. They therefore act purely to elevate and depress the abducted eye. The superior oblique acts to intort, and the inferior oblique acts to extort the abducted eye. When the eye is adducted, the inferior oblique and superior oblique become the main elevators and depressors. The superior rectus now primarily intorts, and inferior rectus primarily extorts. How can you remember these eye movements? Well, I draw a simple diagram. This diagram shows the abducted eye due to lateral rectus, with elevation from superior rectus and depression from inferior rectus. It also shows adduction from medial rectus, with elevation from inferior oblique and depression from superior oblique. Finally, for the intorsion and extortion, simply turn the eyebrows into arrows. The superior rectus and superior oblique muscle are both intorters, which act in the direction of the arrow you have drawn.
Pretty cool, huh?
Comment or share your knowledge with others. Please go to...
And he's got a great voice too, very clear. And then that's why we do this when we do this H pattern for testing eye movement. And we're going to do a lab session here at some point where we're going to do some motor function testing that we've done, like we'll do some of the coordination testing and tone and all that, but we'll also do some cranial nerve testing. So we should have time for that at some point here. Let's just show you where the different nuclei that are associated with this are lying and where they're going here. So change this to maybe a yellow here. So this is the midbrain right here. So here's the oculomotor nerve right here. It's in the midbrain. And then this is the parasympathetic nucleus, the Edinger-Westphal nucleus, just kind of behind it. It's also a little medial to that, also in the midbrain. Okay. We will eventually, when we get to the brainstem, we're going to go through all these cross sections. You're going to see these pop up in cross section. We're not going to do cross section today. I don't want to blow you away with that yet. But right now, we're just going to look at them where they lie in a sagittal view, kind of generally what region or what part of the brainstem they're lying in. So you can just see that the oculomotor nerve, cranial nerve number 3, and its parasympathetic component, the Edinger-Westphal, are both in the midbrain. Okay. Then we have the trochlear nucleus right here. And it's in this, it's kind of in this zone. It's kind of almost partially, it's right at that junction between the pons and the medulla, okay? That the pons and the midbrain, sorry, midbrain and pons here, okay? The trochlear nerve is interesting because it is the only cranial nerve that exits, and remember when we showed you the back of the brainstem, it's the only cranial nerve that exits from the back of the brainstem. And it actually crosses as it exits. So it's unique, and that's the only cranial nerve that crosses as it exits from its nucleus and exits off the back of the brainstem. All the rest of the cranial nerves either exit from the front or the side of the brainstem, and they don't cross as they come out. Okay, doesn't mean that some of the tracks from like the cerebrum going down to especially cranial nerves that you have voluntary control of, those cross, but this one crosses as it comes out. So kind of an interesting nerve. And then the other one is the abducens nucleus. The abducens nucleus is right here. It's fully in the pons. There's the pons right there. This one's also just a little unique in that it sits up here, you know, a little bit up in the pons, and it actually, the fibers descend down to go and exit out of that pontomedullary junction. Okay. So it just means that if you could have damage to different regions of the brainstem and still catch some of these abducens fibers if you're anywhere within this region here of damage to the brainstem, just because those fibers are having to traverse down a little bit before they exit. Let's talk about coordination. All of our eye movements are synergistic. Our eyes never move by themselves. They always move together, right? I mean, if your eye's moving by itself, that usually means something's wrong with you. There may be some people on YouTube who can move an eye by itself, but normal reflexive eye movements or any kind of movements you do, the eyes need to stay together because that's how you stay focused, that's how you get binocular vision, and they have to be synced up, okay? The thing that helps you do that, and it also has to be synced up with your head movement, right? Either you want your eyes to stay with your head and eyes and head move together at the exact same, or you want your eyes to stay locked in and move the exact opposite degree that your head is moving. So you need to be able to do both of those things. And what keeps that ability of your eyes, your inner ears, and your neck muscles all to know what's happening with each other is this medial longitudinal fasciculus. It has this medial longitudinal fasciculus gives you a direct connection between the oculomotor nucleus, the trochlear, the abducens, and the vestibular nuclei on both sides, okay? And also with the descending tracts and also the spinal accessory nucleus down in the cervical spine. Those are mediated and help move neck muscles via the medial and lateral vestibulospinal tracts because they're coming off those vestibular nuclei, but this is that medial longitudinal fasciculus, which some people refer to as the medial vestibulospinal tract once you get down into the spinal cord, but some people still call it the medial vestibulospinal tract down there, but there's also a lateral vestibulospinal tract. And you're going to get more into that when, again, Megan Charts comes in on next Friday, or that's not next Friday, next Tuesday, I think. I think you have her Tuesday. Who's actually, yeah, so you'll get that next session. She'll talk more about the MLF as it connects to the vestibular system and its regulation for that, for balance and so forth. We have different types of synergistic eye movements, okay? The first one we're going to talk about here is the saccadic eye movement. Saccadic eye movement is by command. This is saccades or voluntary eye movements. You are directing your eyes to move to a different direction voluntarily, like you're choosing to move directions of the eye. This is the way you test for this typically is you hold out a couple fingers like this, the patient's looking straight at you, and you just say, look to my left, and you wiggle your finger, and you have them look to the finger that's wiggling, and they're keeping their head still though, and they're just doing this, looking up, looking to the eye, and they're consciously choosing to look to that eye. That's called saccades. And you should be able to move your eyes to command and move them in the direction you want. And there's a very specific part of the, there's a primary motor strip, and then we have that supplementary motor area. right in that transition zone between the supplementary motor area and the primary motor strip, there's a motor area just for that saccadic eye movement. It's called the dorsolateral frontal eye fields. Don't have to know that right now, but the dorsolateral, it's a little area right up in the motor area that is for moving your eyes to those saccadic areas or for voluntary control. The next type of eye movement is pursuit. All the rest are relatively automatic or unconsciously controlled. So pursuit is once your eyes have locked onto an object, they'll just stay with the object without you having to think about it. So usually what you do is you use a conscious saccade to get to the object you're trying to look at. So you voluntarily look to the object. So this would be like in baseball or basketball, whatever. Somebody hits a ball, you're out in the outfield, you use a saccade to look for the ball. Once you lock onto the ball, you use pursuit, or like some people call it smooth pursuit, because it should be smooth. You should smoothly be able to track an object that's moving, as long as it's not moving too fast. If it's moving really fast, sometimes you don't have chance. You have to use saccades to catch up to it. So you're tracking it, it's moving too fast that your occipital lobe can't track it. Then you have to use a corrective saccade to catch up with it later. But most objects move at a rate that we can keep it in our vision and just use this smooth pursuit. And that's mediated by the occipital lobe. The occipital lobe, once that image of that object is there, it'll send signals to your eye muscles just to keep tracking that object, unless you choose to divert away from it with another saccade. And that's occipital lobe. And then we have what's called vestibular positional movement of our eyes. So our eyes, depending on our head movement and so forth, or orientation of gravity like this, if my head gets tipped to one side and I need to tip my head this way, or if my head's this way, my eyes got to do this and rotate, that's mediated by connections with the vestibular system, okay, that tell your eyes to move in the right direction, typically opposite of the head movement that your vestibular system is registering, okay? And then we have convergence. Convergence is where your eyes both come together like this as an object gets close and you're trying to focus on a close object, and that's a midbrain thing. Once your eyes are locked on and this object keeps getting closer and closer and closer, your eyes start to come like that together, where you actually contract the two rectus medius, medial rectus muscles. That's convergence. Okay, that's a midbrain function. And so we would typically, when you test somebody in the clinic, and Megan will go over this, you test for saccades by having them look to, either objects on the wall or cards or your fingers with their head still. Then pursuit, usually what I'm doing is when I'm testing their eye movements, their extraocular muscles, if they're tracking my pen or my finger that I'm moving, that's also a test for pursuit. At the same time, you're looking, is there any nystagmus? Are they having trouble keeping up with your finger? Are they making corrective saccades even though you're moving your finger pretty slowly? So you've tested then pursuit plus their extraocular muscles. And then the vestibular positional, there are tests that Megan will go through for testing connection between your inner ears and your eye movements. Then convergence, usually what I do is after I do the H pattern for the test of this, then I just bring that pen to their nose and just ask them to focus on that, and I look for the convergence so that you can test all that really quickly. So the pupillary light reaction, which is when you shine the light into the eye and you get the constriction of the pupil on one side, and the consensual light reaction, where the opposite eye also constricts a little bit, and the accommodation reflexes all require an intact optic nerve to get the light in and an intact oculomotor nerve to create the response. You need both the afferent and the efferent component to work properly, okay? And so this is just showing you some of the connections here. So here's using a pen light into the eye, and this is to the left eye. That is registered in the retina. It's coming back here, that signal. We deliver some of that light signal to that pretectal area, and this is where that Edinger-Westphal nucleus is. There is bilateral connections here, you'll see. And so what that does is it actually stimulates, this is the pretectal area, and this is Edinger-Westphal. It's just in front of that pretectal area. Parasympathetic nucleus of the oculomotor nerve, here's the preganglionic, remember parasympathetic nerve fibers have kind of longer preganglionic fibers, so this is the longer preganglionic, and then it goes to this little ganglion called the ciliary ganglion. And then you have your shorter postganglionic fiber that goes to the ciliary muscle, and you're going to get some constriction, and you're going to get the pupillary constriction. Okay, so parasympathetic does pupillary constriction, sympathetic does dilation of the pupil. Okay, and you're going to get that bilaterally with just shining the light into one eye. Okay, when you do the accommodation reflex, so accommodation reflex, when you bring in the object like this, is the convergence plus a little bit of pupillary constriction and increased curvature of the lens. Okay, that's all three components are part of this accommodation reflex. And that's all mediated by these connections in the midbrain true. You've got bilateral connections to the medial rectus muscles that tell them both to turn on and bring the eyes in. You got those connections with the Edinger-Westphal nucleus to drive the constriction of the pupil and the curvature of the lens. And I actually kind of just learned something today. I always wondered, if you want to increase the curvature of your lens and make it focus on a closer object, so I always wondered why you contract this muscle. I thought if you contract the muscle, it would pull the lens more flat. It just seems like you would pull that, if you're contracting a muscle, it would pull the lens flat. But this is what it looks like on a side view here. So this is the ciliary muscles, this little bundle of muscle fibers here. And when it's relaxed, it actually, there's tension on these little fibers here, these ciliary fibers, like little tendons almost, that keep this pulled out flat. But when you contract it, it actually kind of bulges and bundles up and actually creates slack on those tendons versus pulling on them. You'll see that you kind of see how this kind of, it actually pulls the eye in a little bit this way, the edge of the eye, and it bulges inwards like this. And by the fact that it's bulging inwards, it creates slack in those tendons, which allows your lens to kind of come together and get thicker. Okay, so because your lens has built-in elasticity to it. So when they're actually relaxed, your lens is getting pulled more taut. When they contract, they kind of bundle and bulge up and create a little slack on those tendons. So it's just kind of opposite of what you think of typical muscle function in your musculoskeletal system. So I learned something new after 25. I just this morning I'm like, how does that work really? I want to find some more detail on that. Not that it matters to you as a therapist. You're kind of be able to test that, but it's kind of interesting. Got to do something to keep the job exciting. So this is showing you, you don't have to know the detail of this, but I'm just showing you these are the connections that all contribute to that. This is the accommodation. So, first of all, you got to get light in. So you get light in here. Some of that information goes back here to the occipital lobe, and then some of that's transferred back up to the pretectal, but there's some also branches coming off here that they don't show. And just showing you the connections between the oculomotor nerve that are going to the bilateral medial rectus muscles, and then also going to the ciliary muscles via the Edinger-Westphal nucleus to create this accommodation reflex. So, lesions of the cranial nerve, number 3, 4, and 6. If you have lesions of those, you'll typically notice some things like this. With cranial nerve number 3, you'll get a little bit of ptosis, which is a little bit of the eyelid will drop down a little bit. So their eyelid will look a little closed on one side. You will often get pupillary dilation. Their pupil will be blown out because normally the oculomotor nerve keeps that pupillary constricted a little bit. You usually have a balance between your sympathetic and parasympathetic. Your pupil is usually in the middle somewhere, so it can get bigger if it needs to, or it can get smaller from there if it needs to. So you'll notice that one eye, if they have an oculomotor nerve damage on one side, their pupil will be blown out or dilated because you don't have the parasympathetic control keeping it counterbalanced and a little bit constricted. And you'll have some type of paralysis of eye movements. Okay, let's see if this works. I forgot that. This uses, what is the thing that no longer works anymore? What's the not Java, Flash, Adobe, was it Flash? Adobe Flash or whatever. So it used to work, and I think it uses Flash, and it may not work now because I think we just that functionality is gone now from like Chrome and stuff. It doesn't. Darn, because this was a kind of a cool program. You actually look at some eyes in front of you, and it follows your cursor. So wherever you move your cursor, it follows, and then cannot download the information requested. I want to see if I can. There's another. I'll look and see if I can get if they've got an updated version or something. And you could then go in and click on each eye, each muscle, and take the muscle away, and then see how the person looks with that. And then you do the test. You can actually take your cursor and have them follow your cursor and do the little H pattern test that we do. So we typically start here, go over to one side, go up, down, then come back to the middle, go to the other side, go up, down, and that tests all the extraocular muscles. So I will have to see if I can find a better version of that. This is just showing that uniqueness of the trochlear muscle. So this is the trochlear muscle. This is the trochlear nucleus, and this is in the kind of in that little right between the midbrain and the pons. And this is the one. This is anterior. This is posterior. And so remember, I said it exits out the back, and it crosses over as it exits out the back of your brainstem. Then it goes to the front to go to the trochlear muscle, opposite of what the nucleus was on the opposite side. Let's see. I thought I had a. I might have the wrong version of this pulled up here, but that's okay. I had a link to showing some testing there. Let's take a break here. All right, we are on. I'm recording. Sorry about that. All right, these cranial nerves we're going to move through pretty quickly because they're less clinically relevant to us. We're on number 9, glossopharyngeal nerve. Pharynx, pharynx, glosso, it kind of tells you a little bit about where it's at. It's a mixed nerve, mostly sensory. Okay, what does it do from a sensory standpoint? You get sensory information from the soft palate and the pharynx, and taste from the posterior third of your tongue. Basically, back of your throat. This is where the sensation in the back of your throat and the posterior third of your tongue. Okay, it also has a little bit of afferent fibers that contribute to some regulation of your autonomic nervous system via the carotid sinus and body. From the carotid arteries come in and tell you about pressure in those vessels and those go to, you'll see in a second where those go. Then we have the motor part, which is really a very, very small motor part. It innervates just one little tiny muscle, the stylopharyngeus muscle. Did you guys learn that in anatomy? Stylopharyngeus muscle, that's innervated by glossopharyngeal nerve. The parasympathetic part of this, which isn't the efferent, parasympathetic part of it, goes to the parotid salivary gland. Okay, so it does innervate a salivary gland, the parotid salivary gland. And it is the afferent limb of the gag reflex. So that sensation in the back of your throat, that's the afferent part of the gag reflex. Vagus is the efferent part. This is how the information tells you there's something in the back of your throat. Oh, so the nuclei, see, it doesn't say nucleus, the nuclei of cranial nerve number 9, it's got 4 separate nuclei that contribute to its function. We have the salvatory nucleus. We've seen that salvatory nucleus before with the facial nerve, right? The glossopharyngeal also uses the salvatory nucleus to supply the parotid gland, okay? We also have the solitary nucleus, which we saw the solitary nucleus also being used by facial nerve number 7, or the facial nerve, cranial nerve number 7, for its taste as well. So the posterior third of the tongue taste also goes to the solitary nucleus. Then we have this nucleus called the nucleus ambiguus, and it's in this region. You'll see when we get to the cross sections of the brainstem. It is a hardly defined nucleus. You can't really see. It's an ambiguous sort of nucleus in the medulla, the nucleus ambiguus, and it is supplying that muscles of the motor of the stylopharyngeals, and then it borrows the spinal nucleus of cranial nerve number 5 for sensation of the soft palate and the pharynx. That information goes to the cranial nerve nucleus. That's another reason why that nerve is so big, because it also is taking in information from the back part of your throat, is that afferent information goes to that cranial nerve number 5 nucleus. This is just showing you where those nuclei are located. Here's the salvatory nucleus, a little tiny nucleus here up in the upper part of the medulla that goes to the parotid gland. Here's the solitary nucleus, which is bringing in that taste information from the posterior third of the tongue. Spinal nucleus of cranial nerve number 5 is taking in that information from the soft palate and pharynx, the sensation from the back of your throat. Nucleus ambiguus, right in here in the medulla, going to the stylopharyngeus muscle. Then here's the carotid sinus and your carotid arteries there. That's going back into the solitary nucleus. Lesions, if you have lesions of the glossopharyngeal nerve, you could lose your gag reflex. You could have difficulty swallowing, dysphagia, because you can't feel the back of your throat. If you can't feel the back of your throat, you can swallow down the wrong pipe, you can get into your lungs. And also some decreased salivation. They might get some dryness of their mouth. Cranial nerve number 10, the vagus nerve. Next one down, so that's this guy right here, cranial nerve number 10. It's a mixed nerve. It has sensory and motor to the larynx, pharynx, and visceral motor, which drives visceral function, okay? The parasympathetic visceral connections that we have for driving autonomic efferent to the viscera. That's the parasympathetic is what we mean by that. There's the parasympathetic motor, the larynx, pharynx, trachea, lungs, heart, GI, pancreas, gallbladder, liver. So the vagus nerve just has extensive visceral connections. And it's also the efferent component of the gag reflex. So the contraction of your throat during the gag reflex is driven by the cranial nerve number 10. Cranial nerve number 10 has 3 separate nuclei associated with it. It's got the dorsal motor nucleus of cranial nerve number 10. That is the visceral efferent. That is what drives the parasympathetic control of your viscera. Even though it's called a dorsal motor nucleus, it's driving visceral parasympathetic efferent activity of the parasympathetic nervous system to your viscera. The nucleus ambiguus, so this isn't really a true motor. I mean, it's more parasympathetic efferent. It's really visceromotor. So like it was better if they called it the dorsal visceromotor nucleus of cranial nerve number 10. There's the nucleus ambiguus, which we just saw, that also was shared by the glossopharyngeal nerve. That goes to the stylopharyngeus, but this is the motor to all the other muscles of the larynx and pharynx, excluding the stylopharyngeus muscle. And then we have the solitary nucleus, which again, here it pops up again. It's being used now by 3 separate nerves. The solitary nucleus, the visceral afferent information comes in to help modulate parasympathetic control. I don't know why they need to do that in the middle of the freaking day, right during prime teaching time. Visceral afferent also goes to the solitary nucleus. And we saw a taste for cranial nerve number 7 and 9 also went to the solitary nucleus. So it's lots of stuff going to that solitary nucleus. This is just showing you some of those connections here. Here's that dorsal motor nucleus, that visceromotor nucleus that's going to go down to your viscera to drive parasympathetic outflow, to drive those liver, gallbladder, pancreas, lungs. Here's the solitary nucleus right here. That's visceral afferent information coming in, telling you about the state of those organs and the state of your viscera. And then the nucleus ambiguus, which is the red one here, that motor nucleus, it's going to all the rest of the muscles, the pharyngeal and laryngeal muscles. Lesions, if you have lesions of cranial nerve number 10, you can have difficulty with speaking, so dysarthria, because the laryngeal and pharyngeal muscles are really important for speaking. Swallowing, you can also have dysphagia because of difficulty with swallowing processes with those muscles being weak. You can have loss of the gag reflex. This is the efferent part of the gag reflex. Digestion can be impacted and poor because if you lose visceral drive to your gastrointestinal tract of the vagus nerve, they can have constipation and have poor digestion. You also will notice asymmetrical elevation of the palate. So if you go, this is where you tell them to go, ah, and you're normally looking for the palate to go symmetrical, and you see the uvula sitting back there, right? So the uvula should just go up symmetrically. If you see the uvula deviate to one side, that is meaning asymmetrical elevation of the soft palate. That could indicate cranial nerve 10 damage. If you have a patient who looks like they're having some swallowing difficulty, this is where you walk into a patient's room, they're eating something and you notice they're kind of choking on it, or they seem like they're having trouble swallowing. You're going in to do your evaluation and you're wondering, hey, does this person have a speech therapy evaluation coming up? Should they be eating that? Should they be drinking that thin liquid? Hang on, I noticed you don't have a speech therapy consult. Can I have you say ah, and you notice their soft palate deviate? We may want to just hold on giving you this apple juice right now that you're choking on, and let me talk to the nurse. Let's get a speech therapy consult in here. That's as much as I'm going to do with that. If I notice that they have some trouble with swallowing, I can just see if the uvula is deviated. And outside of that, that's just like, all right, put it in the speech therapist's hands to check out their swallowing at that point. Okay. So that is cranial nerve number 10. Now we're on 11. This is going to go quick. Overview, pure motor. You've already learned this one. Spinal accessory nerve. It goes to the SCM and the spinal and the upper trap. Sternocleidomastoid and upper trap. Okay. The cell bodies for this, the accessory nerve nucleus is actually in C1 to C4. So in that C1 to C4 region, if you take cross sections through there, you can see the spinal accessory nucleus here, and also the spinal nucleus of cranial nerve number 5 extends down into those upper cervical segments. And it has, fortunately, it just has one nucleus associated with it, just the spinal accessory nucleus. It's pure motor, so, and it's in C1 to C4. And that nerve comes out down your cervical spine, actually goes up into your skull, and then back out. It goes up through your foramen magnum and back out a little hole to go back to those muscles. Don't ask me why, it just does that. So here it is down, this is your cervical spine down here below the medulla, and then there's that spinal accessory nerve going to those two muscles. Lesions, if you have lesions to the actual nucleus or the nerve, that's a lower motor neuron problem, right? This is going to striated muscle. If you damage the nucleus of the nerve, you're going to have weakness ipsilateral to the lesion. What's interesting about the SCM and the upper trap is they tend to have a lot of bilateral innervation. So if you have damage to cortical tracts coming down, or even the midbrain tracts, you still tend to have some decent function bilaterally because they get bilateral innervation from the supranuclear areas that come down and tell that spinal nucleus, you get a lot of bilateral innervation because remember, these tend to be innervated by medial vestibulo or medial activating system tracts that tend to work, these postural muscles tend to work together. So when somebody has a stroke on one side of their body, they don't often have lots of weakness in the neck muscles on the opposite side. They tend to still have some decent function of their postural paraspinal muscles on each side because of the bilateral innervation. Cranial nerve number 12, hypoglossal. It's motor, goes to the tongue. Has both some voluntary and reflex circuits. So the voluntary is driven by the cortex. Stick your tongue out. You know, if you want to actually move your tongue, curl your tongue, move it left and right, you have voluntary. But when you're chewing, swallowing, that's reflexive. And that's mediated by some brainstem reflexes that do that. Okay? And here it is. It's got kind of a little bit of a long nucleus, and it's got these multiple rootlets that come out of it that are along that ventro-intermediate fissure along the side of the brainstem, and then go to your muscles on each side of your tongue. You have a left and a right nucleus, and go to left and right tongue. Okay. If you have damage to the actual nucleus or the nerve as it comes out, it's going to cause weakness on that same side as the lesion. If the lesion is in the brainstem or the nerve, it's going to cause an ipsilateral loss of function. So what's going to happen is if you ask your patient to stick their tongue out voluntarily and they're weak on the left side of the tongue because of damage to the left hypoglossal nerve or nucleus, the tongue is going to actually deviate towards the left side because the right side of your tongue is going to push out and it's going to push the tongue over to the left because it's not being balanced. Normally your tongue muscles push out equally, but if this left side's weak, the right side's going to push out farther than the left, and your tongue's going to then deviate towards the side of the lesion if the lesion is in the nucleus or the nerve. However, if the lesion is in the brain, for the voluntary control, you have cortical bulbar fibers that are going down to that nucleus. If the lesion is in the brain, it's going to deviate. So the right side of my brain is telling my left hypoglossal nucleus and nerve to send the signal out. So if the lesion is in the cerebrum or supranuclear, somewhere above the nucleus, the tongue is going to deviate to the opposite side of the lesion. Does that make sense? So if the lesion is up in the brain on the right side, the tongue is going to deviate to the left. But if the lesion is in the nerve or the nucleus on the left, it's going to deviate to the left. It's going to deviate ipsilateral to it, to the lesion. Okay? If it's in the brainstem or the nerve, ipsilateral weakness. If it's in the cortex above that, it's going to be contralateral weakness. And you just got to think about if it's, which way is that tongue going to deviate based on where the weakness is. Right-sided cerebral lesion, left-sided tongue weakness. Tongue is weak here, right side of the tongue is going to push it over to the left, so it's going to deviate away from the lesion. Lesion is in the nucleus or nerve on the left side. That causes weakness on the left. Stick the tongue out, right side pushes it to the left. It's going to deviate to the same side as the lesion in the nerve or the nucleus. This is kind of an interesting picture. So this is showing you the cranial nerves laid out here, but just the 12 cranial nerves on either one side or the other. It doesn't show you, these would be superimposed, so everything on this side you should also see on this side, and everything on this side you should also see on this side, but they're just laying it out so you can appreciate these easier. The only thing I want you to appreciate right now is when we get down, this is the pons in this area, this is the medulla. So when we get in this region here and we start taking cross sections through here and start looking down at these cross sections, we see a lot of cranial nerves that are in that area. Some of these longer cranial nerves that extend up and down. So when we do cross sections through the upper medulla, through here and the mid medulla, we just tend to catch some of these longer cranial nerves, and there's a lot of them in that area that exit out of that pontomedullary junction that we might catch. Okay. Descending control of motor cranial nerves. This is the motor cranial nerves. This is via the cortical bulbar and limbic pathways. Okay. So this is for voluntary control of cranial nerves. So we do have some, I can close my eyes on command. I can open my mouth on command. I can stick my tongue out on command. Those are the voluntary parts. We also have these more reflexive in nature, but not truly reflexive. They're driven by some of the limbic control, emotion. Most of our communication is nonverbal, and it's driven by limbic system connections. We have some projected fibers that are coming from our limbic system down to these nuclei of our cranial nerves, especially for facial expression, okay, and for movement of our mouth and tongue and so forth, and a little bit as well. Most cortical bulbar fibers cross. It's just like your body is. If you're sending a signal from your cortex to drive voluntary control of your face and tongue, then it's a crossed signal. It goes from one side of your brain to the other opposite nucleus. Just like your body, moving your distal limbs and so forth is mainly crossed, contralateral. These cortical bulbar fibers mostly are crossed. I say mostly because remember the facial nerve, the upper part of the facial nerve nucleus gets bilateral connections. So when you have damage, you don't have to one side of the cortex, you still tend to have mostly normal upper facial function because it's getting bilateral connections. But most of the rest are purely crossed. So a lesion at the level of the nuclei within the brainstem or the lower motor neuron as it exits will cause ipsilateral weakness, where lesions above in the cortex will cause contralateral problems. Okay, makes sense for these motor neurons, these voluntary motor control of the cranial nerves that we have. And we are done. We got done early. Got an hour and a half to study.